flash stream is ready?
Yeah, start.
Okay. No. تقولي بطل.
Speakers one by one or in discussion like that? One by one, no?
Yes.
Give this mic also.
Take him out.
Use this mic also. Both.
You can.
But they are using that mic. That's why. Magnet. Magnet.
صوت شغال؟ زين الموسيقى. الموسيقى الفيديو.
Just keep this mic also.
Yeah, let's نحط الدكتور hook him up. حياك الله هلا بالحبيب كيف حالك؟ يا مرحبا هلا وغلا حياك الله. So you hook him up. We have another mic for those speakers.
But this is for all camera. You can use other mic also.
Which one?
Yeah, hand mic also.
حق اللايف
This is for the live stream.
والمايك هذا.
Yeah.
لا can use the mic.
Yeah, we will give both. We will give both.
Okay.
And this for the
هذا مهم حق تسجيل اللايف ستريمينج.
live streaming.
تمام.
Hide.
Should be the other way. The mic should be off.
Yeah, that one also no problem.
Will it catch the sound like
Yeah.
this?
حطه كذي.
أو على هذا جوز.
It's here better because cable will hide.
Is it open now?
هذه حق اللي هناك بس الصوت الداخلي راح أعطيك هذا.
اوكي. وين الصوت الداخلي وين؟
هذا.
هني؟
سماعة إيه.
هذا مكان ثاني يعني.
هذا حق
تسجيل؟
الكاميرا اللي قاعد يسوي لايف ستريمينج حق الشركه كلها.
ممتاز.
مكاتبهم والادارات الثانيه وعندنا ايضا مكاتبنا اللي برا.
وهيك حلو. مثل تسوي بودكاست.
بودكاست احنا عندنا بكندا وعندنا بسنغافوره وعندنا كثير من دول مكاتبنا شغاله ويانا.
ممتاز والله.
بارت اوف البوليسي ان اي ايفنت شود بي فاللي تشوفهم دائما الحضور مجرد حق الصوره لكن الناس قاعد تشوف منه.
بالعكس لا بالعكس خير وبركه. عادي اشرب قهوه وانا اسولف. اكرمك الله نسيت اقول لك. هو نفسه ولا غيره؟ لا مش ده. Yeah. Yeah.
Another things that maybe the hidden patients are having without being noticing what they are having. The other guest who will be with us is Dr. Darar Al-Khair, who is a consultant cardiologist. He will be talking about or cardiovascular issues, and with particular emphasis on the smoking cessation. He is one of the specialists in the nicotine addiction therapy in Kuwait, and he will be talking also about that. I won't take a lot of your time. I'll leave the floor for Dr. Ahmed, and I'm sure, inshallah, he will be having an amazing presentation with him. Please.
Thank you. Assalamu alaikum. Good morning and welcome to Movember. I would like to thank Dr. Sajid for his introduction and also for his kind and generous invitation. It is a real pleasure to be among all of you here. And feel free to ask questions or interrupt me even halfway through. Or if you would like to save some of the questions at the end, by all means, feel to do so. So the topic that I actually have selected is men's health, the hidden patients. There are many patients that we know about, and there are many patients that we don't know about. So the objectives of the talk, to give you a flavor about the history of Movember. How did this all started? We've been hearing this very frequently lately in the media and the news, and it would actually give you an insight to know a bit of history. How did all this start? Also, we need to touch base on why men's health matters. At the same time, we will focus on prostate cancer, testicular cancer, and I've actually left a few questions because one of the other objectives is actually you guys. So you will be able to actually sit the last talk that we need to talk about. So what do you need to know about in terms of men's health? Well, the first fact, as men, we kill ourselves 3 times more often than women. This is a global study by conducted by the World Health Organization. And what I mean by we kill ourselves in terms of physical illness and also mental illness. So it's not only the mental illness issue. So where does the concept come from? How did it all start? Well, it actually started in Australia by 2 chaps, very lay person. They were not actually a professional person in the medical field. They were chatting in a bar, and they discovered that everybody in 2003, they don't wear any mustaches. Everybody, people in the West, they shave their beards and mustaches. And they discovered men were actually talking in the bar about everything except talking about health issues. So they came up with the idea, well, why don't we actually try to find out how to engage men to talk about their health problems, medical conditions, where to turn up to if they need help. They also discussed how we can raise funds to promote more health awareness. And they started in 2003 with 30 of their initial circle in terms of their friends and colleagues. After 15 years, they have managed to actually raise 700 to 800 Australian dollars. And I forgot to mention that Travis and Luke, the 2 friends who actually started this, they were from Australia. What is more interesting now, you can even go to Google and YouTube, you will see their talks. They've been invited all over the place. So in the States, other places in Europe, and also in the Middle East, they've been inviting them everywhere to talk about their experience and how they started this. So just to reiterate, Movember is about men growing mustaches, go around, and then people will start asking them questions about health issues. There are 4 parts of Movember: prostate cancer awareness and generating funds for research and promoting education, testicular cancer, mental health, and you cannot spell Movember without having an initiative to move. And this is where the word Movember came. So what is the prostate? and where is the testicle? The prostate is a hidden gland. It is a very hidden gland. It's actually under the bladder at the end of the penis. Most people, one of the myths, people think the testicle is the sign of manhood. The testicle is the one actually which, enable us as men to fertilize and conceive and become parents. But the prostate secretes almost 70 to 80% of the fluid that nourish the sperms. Without this gland, nobody can parent kids. I thought I'll share some of these figures, and I probably would, maybe Dr. Sajid can give a prize to the highest person who actually would identify the first. Who's the first person? On the left.
Owen.
Huh?
Owen.
No?
Warren Buffett.
Warren Buffett. Who said Warren Buffett? Score one. Okay, second one. John Kerry. Third one. That's the Gulf War hero. Giuliani. Robert De Niro. Who's this guy, the last one? Ben Stiller. Who's this one? James Bond. And who's this? All of them have prostate cancer.
Want to point out one more name who's no longer with us, though, because all these people are alive.
Correct.
Norman Schwarzkopf.
Yes,
Everybody knows.
absolutely, absolutely. So this is a very common cancer. Well, I would love to give this talk next year and put some celebrities in the Middle East instead of just showing you people from celebrities from the States. But they are very open. The Western people very open. They're very proud to talk about their illness. They're very proud to share their experience. And we need to break this barrier. We need to support each other more at individual basis and also at the community. So I also borrowed this slide from the World Health Organization. So it tells you here, if you look at the number of new cases in 2018, if you combine both sexes, men and women, prostate cancer alone, although it's a gland that only exists in men, but look at how many cases per year are diagnosed with prostate cancer. There is at least 1,276,000. Look at breast cancer, look at colorectal cancer. The studies here in colorectal and lung, they combine men and women. But if you take them individually, in terms of men, prostate cancer will become number one as the first cancer which occurs every year. That's another study that I borrowed from the World Health Organization, and will focus on the prostate. If you look at the new incidence, and the red bar is the mortality, which means how many people die from cancer. Look at the breast cancer, look at prostate cancer, look at lung and colorectal, don't worry about the others. You will see that the red bar, when you compare it with the blue bar, the volume of the bar is less, which means as urologists, we're actually very successful in diagnosing and also treating and keeping people alive. So the mortality is very less. Look at breast cancer, they're not doing as bad. Look at lung cancer. People get diagnosed, they die early. I do apologize, guys, if you cannot see, I probably would stand here much better. What about Kuwait? Go ahead.
I was living in New Zealand in 1996 to 1997, and I was shocked when I knew that the second highest cause of death for men in New Zealand, the second was prostate cancer. And how is that now affecting our culture? Because in our culture, this is maybe something that we do not share with others. And I know people who did hide their symptoms until it got worse and worse and they couldn't hide it anymore. So I'm glad now we are saying, what about Kuwait? So do we have that?
Yes, I do. That's very, very good question of yours, and I hope I will answer it in the next couple of slides. But thank you for pointing it out. So what about Kuwait? Prostate cancer, look at the red circle, was almost unheard of in 74. now in between 2008 and 12. It's the commonest cancers in Kuwaiti citizen, and followed by colorectal lung. So we have a different, so to speak, we can mimic the West, but prostate cancer is the #1 cancer in Kuwait now. What about the 10 most common cancers diagnosed? I borrowed this from a colleague at the Kuwait Cancer Center, also prostate cancer. Well, the chances of developing cancer, if you live in Kuwait, from 8 people or 8 individuals, 1 of them will be affected by cancer in his lifespan. The others, they may actually be affected by other illnesses and they may die, heaven forbid, from other things. But prostate cancer is the #1. In females, breast cancer. Further.
You say that 1 of 8 will have cancer during his lifespan.
Yes.
How do we do in comparison with the world? Are we the highest percentage here?
More or less the same. More or less the same. And look at the commonest cancer in non-Kuwaitis. I am not a sexist, I am not a discriminatory person, but this study was done from epidemiological point of view to find out if the expatriates who live in Kuwait, and for which we're very grateful for you guys to be with us and help us build this country and contribute to the progress, but we wanted to see if you are guys living different lifestyle, getting different type of cancers. Prostate cancer goes to #4. And we might have some explanations, and there are many things that we actually lack also to explain. Oh, sorry, what happened? So prostate cancer is #4, and in female, breast and thyroid remains up. One of these reasons, I think, because expatriates tend to turn up a bit later, so we pick them up very late in comparison to Kuwaitis. What about the mean age of developing prostate cancer? Well, the majority get diagnosed 60 years and plus, and in the expatriates is more or less the same, so there is not much of any significant differences. And the commonest cancer is adenocarcinoma, which is also a subtype of, in terms of pathology. This is similar to what we have in the West as well. So look at early versus late presentation. So in Kuwait, I'll put this one first. So in the distribution of 2004 prostate cancer cases, according to the extent of the disease, the majority should be actually localized. But we also have some people who are very unknown. And I'll tell you what do we mean by unknown. It means that in their record, we don't know if they presented early elsewhere, and then they actually showed up to the hospital with late manifestations and late signs. So we were not 100% sure. And this is one of the crucial data that we are lacking in Kuwait. And I hope the Ministry of Health will actually work on this. From 2004 until now, even when we picked it up, they still haven't actually put any initiative. And the same for those who are non-Kuwaitis. So I would like to reassure you, from my clinical practice, the majority that I would see them, they actually fit in the localized. Very few actually, less than a third, I would say, present with late disease. What about how good we are in treating prostate cancer? And this is in Kuwait. So we are able to keep people alive more than 90% of the time. And the same for non-Kuwaitis. Here, you will see probably non-Kuwaitis are living, the percentage is higher, but I would say this is a reflection because the total number of Kuwaitis to non-Kuwaitis, the non-Kuwaitis are higher, so that's why the percentage is a bit better. So, worldwide, 35 men as we speak. By the time I finish this lecture, 35 men have died from prostate cancer. In 1985, most men were diagnosed with prostate cancer when they were in their 70s. Now it's actually way less. And it's the most common malignant cancer, sinister cancer in the world. That probably will answer your question. So one of the figures that they take in epidemiology, they look at every 100,000 individuals or people living in a certain area, and they look at the incidence of cancer. In the West, it's almost most of Europe, between 86 cases to 179 per 100,000. In African American, most of the studies were done on African origin as well. They have higher incidence, and we will talk about this later. In Kuwait, we're still way low. Although it's the commonest cancer, it's around 14.5 per 100,000. Is this reassuring? Yes. But if we continue similar lifestyle that we have in the West, I guarantee you in 10 years, we'll be way higher than this. So 1 in 7 can be diagnosed with prostate cancer, but the very good news, even if you get diagnosed with a prostate cancer, you can live with the disease, but not die from it. What about if you have a family history, a father, an uncle, or a brother with a prostate cancer? Well, that will put you at a higher risk, at least 4 times of getting prostate cancer. So if you have a family history, please make sure you see a urologist and get it checked, even if there is an age gap between you and your brother and father, but get it checked. And I will tell you at what age you need to be more aware and seek help. Most of you heard about screening for prostate cancer, i.e. going and getting checked up. Do I have the cancer? Will I have a higher chance of getting it? The goal of the screening is to help you guys and everyone else to understand the condition, get treatment early if needed, and also at the same time let you have a very high quality of life. This is a very interesting slide. If you have a family history of a breast cancer, a sister, a mother, an auntie, you have also a higher chance of getting prostate cancer. And because they share the same gene. There's 2 genes that you need to be just literally aware of. The BRCA1 and 2. If you carry the BRCA1 gene, and by the way, we have a genetic screening for this at the Cancer Center. If you carry this gene, or somebody carries this gene, you are 4.5 times of getting prostate cancer. This is Angelina Jolie. Now the BRCA gene, they call it the Angelina Jolie gene. And you all heard about the story that she actually had her 2 breasts removed because she carried that gene, and her mom had ovarian cancer and breast cancer. So she decided to actually remove the breast and the ovaries.
Excuse me, can someone get the prostate cancer without this gene?
Yes, but if you have the gene, you're at a higher chance of getting it. But it can be insidious. It can happen in men, and the majority actually in men, 90% in men, it happens without having the gene. Only 10% are hereditary. Yes, we do. I will show you the slides. Excellent question. You guys, next time you should be giving the talk. Well, really, very good information. So there is an increased likelihood of being diagnosed with prostate cancer if you have a family history of breast cancer. Those who comes to my clinic, I literally dissect every single detail about, I get patients asking me, doctors, why are you asking about breast cancer? I'm coming to you with a high PSA. Why do you ask about my family tree in breast cancer and moms and aunties? And then they get shocked when you actually tell them, well, this is for your own sake. If you have an African origin, people who have dark skin, black in origin, they are at a higher chance of getting prostate cancer. Also, Asian men who lives in the West, they end up following similar epidemiology and natural history of the disease similar to American people who are actually, white skin. It's interesting. If they would stay where they are, the chances for them to get cancer is less. So there is a huge element of environmental factor that until this date we don't know about. But we know that there is a link. So let's be more positive. Dr. Ahmed, you've scared the hell out of us. Tell us, what do we need to change?
I have a question. Taking age, environmental factors, lifestyle, which are the biggest factors?
Age.
Followed by?
Prostate cancer is disease of old age. Cancer is disease of old age.
Then followed by?
Followed by family history,
Not lifestyle?
not lifestyle.
Why is that?
Because there are other things in lifestyle that you can do that people have been counteracting it and minimizing the risk. And these are one of them. Tell me if you are actually eating isoflavonoid, and then you'll say, what the hell is this, Dr. Ahmed? Legumes, lycopene. Well, what is this? You guys go to restaurants, you go to avenues every Thursday and Friday. What is this? Edamame. And? These are derivative from soy. This is tofu, similar to cheese. So make sure you put a lot of this in your diet. It's very protective. It is very evidence-based. Okay? Wait a second. What is this? These are the legumes. اللي هم شنو؟ البقوليات. Okay? So plenty of this in your food, please. What are these? Broccolis, cabbage, اللي هم الملفوف, ورق عنب, broccoli, زهرة, شنو بعد؟ These are very protective from prostate cancer. This should be your best friend. If you're holding, don't hold apple. Next time ask for tomato. By the way, one of the things that my theory, Kuwaitis have a lot of marag, the tomato sauce. It has lycopene, or lycopene, sorry. So lycopene is protective. So make sure plenty of tomato sauce, okay? And make sure when they cook the marag tomato sauce, they don't only use a puree, اللي هو tomato puree, اللي هو معجون طماطم. قول حق الأهل يا عبد الحلال حطي لي 4 طماطات وقطيهم بالمرقة، مو بس بسرعة. Okay, so this is evidence-based, guys. So if you get this in your food, you're already counteracting any other factors that you may have. Is there anything else? Dr. Dharar Abu Mu'adh will like me for this. Yes, statin. If you have been diagnosed with hyperlipidemia and Dr. Dharar and his colleague is writing you your lipid, which is the cholesterol tablets, and you're not liking it, well, statin is protective against prostate cancer. So make sure you actually comply with your medication. Or if you have a father or an uncle, he's, getting treated for hyperlipidemia, please tell him, well, if you treat your cholesterol, you're reducing your chances of getting the most common cancer in men. So what is PSA screening? I will not actually go into details about, PSA testing, but PSA is literally a blood test. Similar to when your doctor ordered a kidney function test or a full blood count, which is just checking your hemoglobin, if you're anemic or anything. So PSA is a blood test. It is easy. It is a protein that we check in your blood circulation. This is get excreted by the prostate. It is a prostate. It's not only specific it's a prostate specific, but it's not cancer specific. So if it is up, it doesn't mean you have a prostate cancer. it means that there is just like a yellow flag that we need to dig in and find out if it is because of cancer or because of something else. So you may have inflammation of the prostate that can shoot your PSA up. Benign enlargement, which far, far more common than getting cancer. 1 in 2 men in their lifetime can get benign prostatic enlargement. This is a pure benign condition. So it can elevate your prostate, the PSA. If you have a camera, a telescope by the urologist to look inside, similar to our colleagues in the gastroenterology when they do endoscopies for the stomach or the colon, they can actually, diagnose their own diseases. So we can actually do cystoscopy, which is a telescope inside the urethra and the bladder. So that can shoot PSA. If you have a catheter insertion, many patients, they have surgery for gallbladder removed or any other things, and protectively, they put a catheter so that after the procedure, the patient doesn't need to go to the toilet the first 24 hours. If somebody is actually just very enthusiastic and order a PSA while somebody is having a catheter or had a catheter inserted, their PSA will be shooting up all over the place. So these things people need to be aware of. Not maybe you as a lay person, but our colleagues in medicine, they need to be aware of this before ordering a PSA. And the function of this protein is actually to make the semen liquidy, not too thick. So that's the function of this enzyme, which is secreted by the prostate and also shows up in the blood. This slide shows you the following. Over 90% of men diagnosed with local or regional, as I emphasized early on. So the majority, when we pick them up, are actually local. They're not distant. And the screening has resulted in actually diagnosing people early, offering them treatment, or what we call active surveillance, i.e. monitoring how this PSA and monitoring the patients, and monitoring the cancer if we diagnose it, and also make people have a very good quality of life. So be aware of PSA controversy and be aware of Google search. This is my enemy, by the way. In my clinic, people just say, "Doctor, I Googled this new treatment and I need to stop this medication. Can you please tell me it's okay?" Or they would have stopped their medication a month ago, 2 months ago, for any condition, not only prostate cancer. And they say, "Well, I'm just coming to check if I'm actually okay or not." Problem with Google, there's a big saying here, absence of evidence is not evidence of absence. So if you don't see it in Google, doesn't mean it is not there. It means probably hidden somewhere. Only experts, when they go to professional and well-known websites, they would actually show you the right evidence. This is one of these studies that made a lot of patients stop seeing urologists, not doing PSA. It's called the PILCO study. But as experts, we can critique these studies. And they had a lot of faults in it. It was a very flawed study because the patients that they recruited for the study, all of them, almost 80%, they had PSA checked in their lifespan. So they have actually ruled out prostate cancer. So they have recruited the wrong patients. But they came up with their own conclusion as well. There are much stronger and more powerful studies which shows that doing screening, selective screening, protect you from dying from prostate cancer. So you literally need to diagnose and treat at least 50 men to save one life. Is this an overestimation? Yes, it is. But if you look at it globally and how many lives that you can save, it is worthwhile. This is also a nice study which was comparing 10 years of diagnosing somebody with prostate cancer, doing nothing, just follow patients up for 10 years, or diagnosing prostate cancer, offering them surgery, or diagnosing them with prostate cancer, offering radiotherapy. And they found no difference, so just leave them alone. The problem is in the newspaper and the media, they they decided, well, nobody need to be treated for prostate cancer. Just diagnose them, leave them alone, let them enjoy their life and not to have the side effects from treatment. The problem is, when I actually looked into the details of the study, well, what happened? They were all low and intermediate risk. They were not the higher risk. The behavior of the cancer get categorized by us as urologists and by our colleagues in pathology. We look at the behavior of the cells. We categorize patients: low risk, intermediate risk, and high risk. So the problem is to make a general conclusion about a study like this, and you totally overlook the patients who had high risk, and then just tell them, well, you don't need to be treated because I have a study which shows this. So this was one of the miscommunication, misinformation, and lack of education. And the first guy is Freddie Hamdi. He's actually from Alexandria. He's an Egyptian, but born, his grandfather was born in England. I actually got trained by him. So when he published this study, everybody attacked him. And everybody was telling, okay, no need to diagnose prostate cancer, or if you diagnose them, don't treat them. But the study was mainly done to pick up low and intermediate category, and just to find out what happens to them over time. And this is just another summary how they actually looked at. Another thing, this is the study of the 10 years follow-up. Look at how many of them they had active monitoring. But look at the surprise. Most of them, by 4 years, they decided to get treatment. They changed their mind. The problem is when you show a study like this and the experts don't go into details and trying to critique it, patients, if they Google this and read one of the journalists writing a small note that, you don't need to be treated for prostate cancer, you can live with it for a long time, can be misleading. But many patients decided over the years to switch, to cross over, to have radiotherapy or surgery halfway through. So as urologists, we don't rely on the PSA. So we do other things. We use different calculations. They're not necessarily done by a blood test. We do what we call PSA density. We put the PSA to the prostate size. We individualize. We measure what's something called free PSA. We have other novel markers. Most of them, they are actually part of studies. We also use now MRI. We use ultrasound, transrectal ultrasound. It's a telescope. It's an ultrasound similar to a telescope. We insert it through the rectum to look at the prostate. So we don't only rely on a test to diagnose somebody with a prostate cancer. So we use other modalities of investigation. And one of the most crucial things is when, say, a urologist or a physician do a blood test for somebody who's 50 years old to check for prostate cancer, and they tell you the PSA is high, you need to have further investigation, and you say yes, but there is a big conversation has to take place before they offer you the next step, and I'll tell you the reason. This is the cancer detection rate by the number of biopsies. What we tend to do, we tell patients that you need an ultrasound and we need to take specimen from the prostate if we need to find out if you have cancer or not. The yielding, the chances for us, if we do, the majority of us will do 12 cores. The chances of us finding cancer in somebody who may have it is almost what? 36.7. So we're not 100% accurate. We can still miss it. And the reason is, say the cancer is there. Even with the best modalities in terms of MRI or ultrasound, and we're just doing random biopsies through the ultrasound that we are doing through the rectum, and we'll try to target the prostate because this is the quickest way. We cannot find another way of accessing the prostate, although now we actually do it through the skin below the testicle. This is called transperineal, but I will not go to the details. Majority are done like this. But look at the chances. So there is only 30% of chance of missing it. And if you take 12 cores, the number might sound high, but you're literally just targeting 0.5% of the prostate. Even when we do the biopsy, there's 40% that we might be underestimating the diagnosis. Unfortunately, when these things get referred by, say, an internal medicine, they refer patients to the radiologist. The radiologist do the biopsies. Urologists were not involved in the conversation with the patients. Patient get the biopsy, it comes back negative. They reassure the patients, you don't have cancer, he goes home. Where it should have been done, the biopsy ideally should have been done by urologist, or the urologist should have been involved in the conversation to tell the patient that despite having a biopsy, that if you harbor cancer, there is a chance of 30% that we may not actually pick it up.
Doctor, how big is the prostate? What's the physical size of the prostate? The normal.
The normal between 15 to 20 gram or 15 to 20 mils. But size has no issues or link to having cancer or even developing symptoms. People can have big prostate, 40 gram, 60, 100, 300. Doesn't mean that they have chances of getting cancer. So the prostate increase as we age. And it just follows the natural history of the disease. Nobody knows why. It is under the influence of the testosterone hormone, the male hormone, but it's normal for the prostate to increase in size as we age. So this is an MRI. So in order for us to increase the sensitivity of, not missing cancer, now we rely on MRI. The last 7 to 8 years, MRI had big say in prostate cancer. So we do PSA, we do MRI, then I would offer biopsies if needed. If the MRI is reassuring, I probably would not offer even biopsies. The problem with biopsies, it underestimates. It also can miss cancer, and it can have complications. People can get infections, blood in urine, blood in semen, and they can get nasty infections out of it, like a UTI or the bacteria spread into the blood. So it is very rare, less than 1%, but we only need to offer it to the right people. This is where MRI now come from. To show you how smart as urologists, I will show you a few things that we do in urology. We use a lot of physics now, medical physics. We use different physiodynamics to quantify how the prostate. We look at something called diffusion weighted image. We look at something called dynamic contrast enhancement. We looked at perfusion maps. We do this with the radiologist, but we look at them ourselves. This is all just to see the pickup of the contrast and different material in the prostate. Now even there is robotics biopsy coming into play, but I will not go into details, but maybe in a few years you will hear that.
Doctor, you are mentioning rheology and pathology. Can you define these medical fields?
Thank you. Pathologists are the doctors who look at the specimen after we take it out. So they look at the behavior of the cells under the microscope. The radiologists are the doctors who actually do the x-rays for you, like the ultrasound, the MRI. They are the doctors who are specialized in reading these images. Clear?
You mentioned testosterone and the effect, the chance of having prostate cancer. The more testosterone your body produces, you are more at risk or not at risk?
Very good question. We all get testosterone in our system. There are no patients who have more testosterone than others, but there are patients who have less testosterone than others. Does it make sense? So everybody has his own testosterone level. You've been born with a certain testosterone level, like a normal range, say from 9 until 30. Anything between 9 and 30 is acceptable. This is normal. There is no such thing called you have hypertestosterone, like high testosterone. It doesn't.
If you go to any gym or something, they give the
testosterone
Correct.
injection.
So what
What I mean, does this increase the chance of?
No. What tends to happen, your body is very smart. So these people who go to the gym get illegal injections of testosterone. There is a small gland called the pituitary gland. It is here. It's almost here. And there is a big story. If you read books, there is a nice book I would advise you to read. It's called David and Goliath by Malcolm Gladwell. اللي هو عن سيدنا داود. And how did he manage to وقتل داود ضرب بالمقلاع هني. And his enemy, the king, who was attacking the tribe, وهذه موجودة بالتفاسير ابن كثير, كان عنده acromegaly. So when he hit him here, it's actually ruptured the whole pituitary gland. So that's what died. So even these things happen for a reason. But this is a very interesting book. So this is actually the gland of life. This is what I call it, the pituitary gland. So if people get testosterone in the gym, the gland, which secretes a lot of hormones, including the hormone which controls testosterone, gets shut down because you're taking a lot of testosterone from outside, so it decides to stop. So it will not affect the overall level. So it doesn't mean you will have more testosterone in your body. It means it's still within the normal range, but your body is going to stop producing it. So who needs screening for prostate cancer? This is another important now message after talking about all these details. If you are a man between the age of 55 to 69, according to international guidelines, seek a urologist help, ask for help. If you have a family history, it is better to seek a urologist help at least 5 to 10 years younger than this. So enough talking about prostate cancer.
Doctor, does the chance go lower after 69?
It actually goes higher.
Then why is it removed from the from 55 to 69?
Why it is from 55? Very good. So by the time you hit 70, you have already passed the critical, time to die from any sinister cancer. So prostate cancer, when it gets diagnosed after the age of 70, it tends to be very low risk in a very low category. So it is easy to follow patients up. Do I offer treatment of patients who's 70 and 72? Yes. There are people who are in their 70s, much healthier than you and me. I have somebody who's 70 years old who runs a marathon, really. He runs a marathon for the MBK that they do every year. So I actually took the liberty, diagnosed him, and treated him from prostate cancer because he has at least 10 to 15 years ahead of him. So treating somebody with prostate cancer is all individual based. Guidelines do exist, but they are guidelines. So you have to individualize. But thank you for that question. I did not cover it in my slide, and it was very good of you to mention it.
Are there any symptoms for the prostate that patient can feel?
Excellent. I did not cover that. I covered it last year. Majority, 99%, no symptoms. And if people have symptoms, i.e. difficulty passing urine, going more frequent to the bathroom than usual, waking up at night 3-4 times, the stream of urine is very low. If they feel more urge to go and pass urine or getting some blood in urine, most of these, they are actually symptoms of enlarged prostate, a benign condition, non-cancer. But when they present with this, we tend to offer an open discussion if the patient wants to be screened for prostate cancer. If they say no, or if they think the evidence is not actually in their side, we will probably not offer them. I tend to be a very opportunistic. I'm very selective when I screen or not screen. Unless somebody has a family history, he's very concerned, he wants to know, then I would offer them. But the majority of prostate cancer, silent. That's why I said the hidden patients at the beginning of the slide. Hidden patients. Can I talk about testicular cancer? I'll whiz through it. If you guys getting bored, I'll just jump into conclusion, honestly. He has been very generous, said, just see how it is. But if you guys want me to stop anytime, I'm conclusion.
Suggestion to you, okay? I think if possible, let's let's keep the focus on prostate cancer.
Okay.
Yeah, especially for this group. And I want to share something with them. We haven't introduced myself. I'm the CEO of Equate.
Very nice
So,
to meet
good
you.
to see you.
Very nice to
Yeah.
meet you. Please come in.
So the reason why this is very close to me in November is 2 years ago I had sent you a note, right? I am,
Take my mic.
Thankfully, I don't have prostate cancer yet. Okay, but my father died of prostate cancer, so I fall into this high risk category. That's why I wanted to talk to you all about, from a patient fear, what you go through it, so that we take the fear away, because I want all of you to live very long, especially if you're struck with this disease or if your PSA is high. Dawood knows about it. 2 years ago, I went to a routine PSA test because I was over 55, of course, and my father had died of prostate cancer. And guess what? My PSA was high. Okay, so there was no doubt in my mind that I had prostate cancer. Okay, because I belong to the high risk category. And so some of you might go through it, which is why I want to share this with you. So with enormous, and I'm not a doctor. So if I'm telling you something that doesn't make sense, always trust the doctor. Yeah, I'm just giving you my perspective on it and an American perspective on it. My number was in the high teens. Yeah, usually it should be less than 4, but as you grow older, it gets up, but it shouldn't be in the high teens. That is definitely a major red flag. So typical engineer, what you end up doing is you go for the complete test, right? So you run to an MRI because you're 100% convinced that you have prostate cancer. Like the doctor said, unfortunately, this one is not very easy to detect. So you go through an MRI, which is a pretty loud, inconvenient procedure. If you have, especially if you have claustrophobia, it's an even more inconvenient procedure. But then you get what is known as a PIRAD score. They give you a number. Your worst nightmare is you get a score that is right in the middle. You're not sure if you have it or you don't have it. Right? Then comes the big decision you have to make, whether you want to do a biopsy or not. And like he had pointed out very nicely, even if they do a biopsy and they clear you, you can't be 100% sure you don't have it. I didn't have to do a biopsy because these famous urologists who saw me in the US asked me to repeat the PSA test, and guess what? It went back down to 2. So why the darn thing spiked up could be any of the random reasons, but I can tell you that 1 month when your PSA is high and you're wondering, whether you're going to die or not, is one of the best phases of life to go through that I wouldn't wish on anybody else. The other thing that we should speak candidly here, especially between us, and and he has been very euphemistic because I think he is definitely much more culturally aware than I would be. If this was any other kind of cancer, the easiest way to cure it is to go get the surgery done and pretty much the PSA drops to 0. Unfortunately, depending on your age, once that is done, one important source of pleasure in life goes away. That is the challenge that the individual has to meet. Okay? Because whether you like it or not, I think at some point in your life, because of family history or age, the PSA is likely to go high. So don't panic when the PSA goes high. There is nothing that I haven't read from a Google or the Harvard reviews and the urologists and all standpoint, but I am a living example where the PSA went high, had an MRI, and the PSA went down. So these PSAs do happen. God forbid your PSA spikes, don't panic. It may not be prostate cancer. But the surgical intervention part is a deeply, deeply personal decision. Okay? Is it worth living a life where you sacrifice a basic pleasure of life for the other pleasures that life offers? Because that is the only sure thing. All this other, where they plant radioactive seeds, I mean, we have we have had 2 surviving equators who we know have prostate cancer across the globe. Some of the others haven't shared it, but we are aware that they have it. But they're living very good, healthy lives. But the psychological aspect of it, God forbid you're diagnosed with it, is as important a situation on prostate cancer as it is for women on breast cancer. Yeah, so we just have to deal with it. Just wanted to share that with the people.
I didn't mean to take away yours.
No, I'm actually, we're very grateful. This is actually what men's health is supposed to be. We need to share experience and we need to talk. You don't need urologists to tell you what to do and not what to do, but this is excellent. And I congratulate you for this and for your encouragement. You want me to proceed or?
Please, let's
There are some interesting things here. about testicular cancer. It might actually help and be useful for your loved ones, your kids, and also other relatives of yours, because this is one of the biggest challenges that we also have in the community. So we've mentioned about the testicle. It's actually an organ which is involved in testosterone, hormonal production, and also producing sperms. But this is an important cancer because we talked about people who are in their 60s and late 50s or mid 50s. What about people who are under 40? So this is another cancer that you guys need to be aware of. And unlike the prostate, which is a very hidden gland, this is a cancer that can be diagnosed by you guys, by well-known education and well-known awareness about it, by performing self-examination at least once a month in the shower, making sure that the testicle doesn't feel any lumps, any bumps, it feels very smooth. Then you will be at a higher chance of protecting yourself from getting it. The problem with testicular cancer is a very aggressive cancer. If you pick it up early, the chances of cure is more than 90%. If you pick it up late, if you get diagnosed or you wait a week or a month, the cancer actually grows quicker than most of other cancers. So it is a two-edged sword. So a 90% cure rate if you pick it up early. And it is an oval-shaped smooth organ. It is equivalent to the ovaries in women. So the ovaries produce the egg. The testicle produce the sperms. The prostate produce the majority of the semen, the fluid, which nourish these sperms that comes from the testicle. So if you feel something firm, especially in the middle of the testicle, seek your doctor immediately. Doctor's help. I've showed you some graphs about prostate cancer. It's very interesting to see the graphs of testicular cancer. In the West, testicular cancer tends to happen between the age between 15 to 30. The problem is, you look at our data in Kuwait, it tends to happen between 30 to 39. So we tend to have this cancer at a later age than our contemporaries, our peers in the West. And we don't know the reason for that. Also, among non-Kuwaitis, it tend to get diagnosed between 40 to 49. So yes, it is a disease which is commonly globally in the age 40 and less, but we're seeing a different trend for some reason. And the majority is a cancer called seminoma, which is also a malignant cancer. And we are seeing the same trends between Kuwaitis and non-Kuwaitis here in Kuwait. And this is the similar pathology, similar behavior of cells and type of disease that we are seeing in the West. But what is more striking, we are seeing it more commonly at a higher age now. The majority tend to be diagnosed localized. This is actually, it means we are catching up at early, which is very good news. And we also have some proportion of patients that we don't know. They are halfway. Are they early or are they late? We don't know according to our records. And this is something that we need to work out really heavily at the ministry. So this is what the testes do, produce hormones and male sperms. And by physical examination, this is what you need to be actually taught. You can actually seek a urologist help. He can show you how to actually learn this. Your family doctor, if he has well awareness about it, he can actually teach you. And you can teach yourself. There are some educational videos that you can find out in YouTube, and I'm more than happy to actually send you some videos to help you to actually know how to feel for any lumps and bumps. So are there any risk factors for this type of cancer? Yes. It occurs in younger men. We said between 50 to 35 globally. Here in Kuwait, we're seeing it a bit higher. But in Kuwait, I've already showed this slide. Beg your pardon, just a replicate. There is a condition called undescended testes. You will be surprised how many parents, they don't know if their newborn child has his testicles back in the scrotum or they are still actually in the groin. We're relying more on nannies, changing diapers. And I'm getting kids, families bringing their kids when they are 7 years old, 8 years old, because the child actually made the parents aware that his testicle is not in the scrotum. He's feeling it way higher up, which is a shame, because these things tend to be in the West, with the education and the family care at the primary sector, they tend to catch this very early. Even pediatricians tend to miss this. They end up focusing on other, heart problems, chest problems, breathing, their brain, their movements, and they totally look at the testicle as the hidden organ. This is the last thing that they would worry about. But having undescended testis, i.e. the testicle which is not in their normal location, puts somebody's later in life at a higher risk. If you actually diagnose this early at an early age, and you fix the testis, you get it from here to there by a very simple surgery, straightforward surgery that takes less than half an hour, then the chances for them to have normal risk factor like anybody else is the same. So just be aware of this. Share the information with your loved ones and people that you care about. So what are the common symptoms? It's a painless mass. We've mentioned that prostate cancer has no symptoms in the majority of patients. Also in the testicular cancer. It's just the testicle is increasing in size without any symptoms. That's why men tend to ignore it if they develop a mass. They would say, maybe, I had a trauma, or somebody, I was playing football or soccer and maybe I had an injury, or maybe I have a little bit of an infection from here and there. Let's just leave it for a week or so. And then they would just leave it for a couple of weeks, and then guess what? After a month, we discover that they have a testicular cancer. And in these patients, they can already pass the early stage, because this cancer grows quickly, not only from outside, from inside. And they tend to spread at a micro level into channels we call lymph nodes, which is the commonest pathway. It's not the blood which the cancer spread to, it's the lymph nodes. It's another channels that the cancer escape the immune system. So is it easy to diagnose? Yes. The gold standard is actually to use ultrasound. Just simple ultrasound for the testicle. We can pick it up very early. Ultrasound is the gold standard. If there is any abnormalities, urologists get involved. And if surgery is needed, I will show you some pictures later on. We tend to do the surgeries from there. We don't make the incision in the scrotum, because the chances of spreading of the cancer to the scrotum is higher. So we tend to make the incision from here, and then we push the testicle up and take it out. The testicle is an organ which was formed near the kidney, inside the belly, inside the abdomen. And then slowly over the embryology, as the child grows, just before delivery, the testicle would actually go down to the scrotum. So it is an organ which is formed inside the belly and then comes down. If we diagnose somebody with testicular cancer based on ultrasound, we do CT scans. Testicular cancer is a very unique cancer. It has what we call also tumor markers. And there are 3 common tumor markers that we order them if we suspect testicular cancer. These are called ECG, beta-HCG, LDH, and AFP. You don't need to know about, but if your doctors tell you that he needs to order tumor markers, that's what he's talking about. Commonest is these type of tumors, seminoma and non-seminoma. I won't bore you with details of this. There are different types of cancers. One has different prognosis. And there are 3 common stages. One which is a cancer limited to the testis. And this is the one that we need to pick up early. It can spread to the lymph nodes. This is stage 2. And it can go elsewhere to different organs, lung, liver, brain. So what's the treatment? Early stage, we make a small incision and take the testis out. And in the majority, this can be enough for patients. But they need a very, very close follow-up, even for the rest of their life. Not like 2 or 3 years like other cancers, or 5 years. So testicular cancer can reoccur, can happen, can come back. But will not come back in the testis because it was removed. It will come back in the belly, in the lymph nodes. And as I mentioned, patients need to be under surveillance after we remove the testis. If the cancer is already advanced, we remove the testis, we do CT scan, we check for lymph nodes. If they are involved, we offer chemotherapy. The chances of cure is very high. So pick it up early and you will be absolutely fine. You can live a very good normal and quality of life. I will jump into a few things, but I want to show you some interesting slides now. So I've chosen the titles Facts and Fictions. So not every lump that you will feel as a cancer, but it is good to be safe rather than to be sorry. So there are other organs in the scrotum. So there's the testicle, there's what we call the epididymis. This is just the small cap, we call it the cap of the testis, where the sperm mature. There's also what we call the spermatic cord, which literally the veins and the arteries, which bring oxygen and nourish the testis. And there are also the lining of the testis. So any of these organs can be the culprit, the guilty party which caused the swelling. But we have to make sure if there is a painless mass that it is testicular cancer until proven otherwise. So this is a varicocele. These are just dilated veins. So this is not cancer. So if a patient feels this, we do ultrasound and we tend to actually clinically diagnose them, and then we do ultrasound if needed. This is something called spermatocele, which is essentially a cyst around the testis, and this is how it looks like in the ultrasound. So the urologist and the radiologist are very safely can rule it out and say, nothing wrong. Or if this cyst is big, we can offer a small surgery, remove it out without affecting anything. There is what we call also lipoma, which is just a fat, and this is how it looks like in ultrasound. There is hydrocele that tends to happen in kids. This is just a fluid collection, and we're shining a light here, and in the slide probably you can see it's a bit, lighter than the rest of the skin. And this is how hydrocele, which is a fluid collection. So these are not cancer. So now look at how the cancer look like. So this is an ultrasound. You can see the smooth surface, and there is a very awkward, abnormal finding here. This is cancer. This is also cancer detected, and this is the remaining of the testis. Here you can also see a tumor. And also here you can see this is right and left. So this is cancer. This is the remaining of the testis. And this is one of the cases that I had. I had a patient who actually, I saw him in clinic, and I told him he needs surgery within a week. So he decided he wanted to have herbal treatment. So he went abroad for a month and came back. The picture underestimated the size. The size of this mass was up to here. So he came back and said, "Doctor, please take it out." The problem is, you cannot make an incision through the scrotum to take it out. This is not the right way, because if you do it, you can spread the cancer through the skin. So I had to make an incision through here, but imagine, how would you take all this through a small incision? Classically, we tend to make 3 to 4 centimeter maximum to get the testis, because the testis is a very small organ. So how would on earth I would take this out? So I had to think of a way. This is not something that you see in textbook. You don't always learn these things even during your training. So you have to, use your experience and improvise. So I used the same approach, but I had to stick a needle to decompress the size of the testis. I did an ultrasound beforehand, and I discovered there is a lot of fluid around the mass. So look at how much blood he was bleeding into the cancer. So I withdrew almost a liter. And then I managed to get it through this small incision. This incision is actually, we are using what we call a retractor, but it's still a small incision. So we managed to get it out. And this is the size of the tumor. Yeah, it was actually what was like that. Yeah. So we can offer patients, if we remove the testis, what we call a testicular prosthesis, a silicone. So not only women can put actually silicone in their breast, We can put a silicone so people they will not lose their image. This is how the cancer can look like after surgery when we cut it. So self-examination is crucial, guys. And this is easy to learn. If you feel anything suspicious than what you are used to, then seek help. And these are just different ways of, feeling for the testis. You can use 2 hands. You can use 1 hand. So if you feel a lump in your testicle or know somebody, see a urologist. So what to do to promote your own health? This is just like a summary. If you are in your 20 to 40, make sure that you watch your blood pressure, weight, any fat in the belly, testicular exam. If you are between 40 and 50, make sure you do the same things in the 40, but also be aware of prostate exam and assessment. If you're between the 50 and 70, also check for the prostate. And by the way, what I mean by weight circumference and blood pressure, it means also factors for heart disease. So people in their 20s, 40s, 40s, 50s, they need to be aware of any risk factors for their heart disease as well. So weight circumference, increasing fat belly, it's an alarming sign that for you to check your cholesterol. If you need to see a cardiologist, a heart doctor, then by all means, you have to do so. And if you pass the age of 70, congratulations. You've passed most of the critical, and then you can enjoy your life and just do a routine check. Make sure you exercise, follow a healthy diet, plenty of tomato, please, plenty of broccoli, plenty of soy sauce, plenty of, بقوليات والشغلات هذه.
So, Doctor, prostate cancer chances are 40 plus? What is the
It's mainly 50 and above. The majority 60 plus. It's almost unheard of. Unless you have a family history, then you have to get checked in your mid 40s or early 40s. So Mark Twain has a very nice saying: habit is a habit, and not to be flung out of the window by the man, but coaxed downstairs a step at a time. You cannot just literally decide, I want to quit smoking, and throw the packet from the window. You have to take steps slowly to get rid of the habit. So you have to take the habit with you and also get rid of it step by step, like going downstairs. So it's not easy to decide, I want to change my lifestyle like this. Just do it gradually, get the support that you need. So in conclusion, be aware of prostate cancer, testicular cancer, how to lead a healthy life. And remember, men can be their own enemies by our own habits. And this is my final slide. Success is not a final failure. Success is not a final. Failure is not fatal. It is the courage to continue that counts. That's Winston Churchill, my favorite politician. Thank you.
Dr. Ahmed, thank you very much for this interesting presentation. And thank you for that last slide about things that we should do to take care of our general health and cardiovascular health per se. And for that reason, we have our other distinguished guest, Dr. Dalal Khair, who will be talking to us about the cardiovascular issues and the smoking cessation. So I'll leave the floor for him. Please.
Thank you.
Good morning, everyone. Thank you for inviting me today for your day. My talk will be shorter, more interactive, hopefully. I was wondering whether it was a coincidence or planned to have the talk of male reproduction system before the heart, which one is more important. But so which one should I use? This one?
Yeah, that's fine, but this is for the...
Okay. Yes. So my name is Dalal Khair. I'm an interventional cardiologist, which means I'm specialized in internal medicine, then cardiology and interventional cardiology. And that means, so I do interventions of people who have heart attacks, and we do the angiograms and putting stents on them. But I also enjoy treating and preventing disease. We have the old say, الوقاية خير من العلاج, or prevention is better than treatment, and it's truly true. And this is by evidence, and we see it in studies that prevention prevails all the time. And medicine is not as pure as we think. It's all, as with any industry, it's driven by money. So because of producing new medications, new innovations produces money, you see all the efforts goes to the doing surgeries and giving new medications, while taking time in preventing and rehabilitation, it's not money generating, so you don't see much efforts or emphasis, in prevention. So today my talk, I will not talk about cardiovascular diseases per se, because it's a huge topic, very big topic. We'll focus today on smoking cessation, which is very easy to say and very difficult to do, and there are lots of myths. We'll talk today about cigarette smoking, vapes, electronic e-cigs, which one is safer or not. So we'll make it, hopefully this will be helpful to you. So which button is it down? Yeah, okay. So stand by him. So I'm not sure. So smoking is not only limited to men. So now men and women, I think they smoke equally, and now with the availability of e-cigs, vapes, even teenagers now, boys and girls, they are smoking. So it's an endemic of everyone in society. So it's not only for men. But I guess I confirm the message that Dr. Ahmed said, men dies more than women. And in particular, cardiovascular disease. So if you don't die of cancer, war, drowning, all of us, human, are mortals. So if you escape everything, the leading cause of death is cardiovascular disease. So that's why it is very important to focus on this. So smoking, psychoactive substances. So it means something that we take that affects our brain and produces an effect. Nicotine, so humans have been using psychoactive substances all along. They've been using tea, which has the caffeine that has an active or an effect on us, alcohol, nicotine, caffeine, as I said, even psychedelic mushrooms. You read about this. Humans have been using this to have an effect on them, whether they use it to connect as a community or as a tribe or a family, to have an experience. Some of them are harmful, some of them are harmless, and some of them are in between. Nicotine, so it's a substance that's not naturally present in our bodies. However, when we ingest it, it goes and acts on receptors in our brain. So imagine you're having a key and you have a door. So that key, if it opens the door, it will have an effect. So let's say relaxation. Okay? So nicotine is not naturally present. So if that key goes, so if we experience a happy experience, you will be happy. And by this, it happens, our brain will produce hormones that goes to our brain, opens that door, and then you will feel happy or relaxed. Nicotine resembles some of those naturally produced hormones in our body, and it will give you an effect. So this is a single brain cell. And if you see this, here we call this as a receptor. So if we imagine this is in a person who does not smoke, he needs only one key or one substance to give us an effect. So smokers who smoke, people take it to feel relaxed, to concentrate, or to feel happy. Or even, smokers, they know, they cannot have a bowel movement unless they have a smoke, because they have trained their body to have they need more substance like nicotine to activate, to give that effect. So keep in mind, this is a normal brain cell with few cells to have an effect. While in a smoker or smokers, they developed a tolerance where because by ingesting an outer substance, which is the nicotine, they have lots of receptors, so you need more substance to have that effect. So I promise I will not show cancer pictures. I will not show you that because all of us know it's bad. So I promise I will not show you that. But I have to say there is no doubt in science that smoking causes cardiovascular diseases, lung cancer, and chronic obstructive diseases, and those are the leading cause of death. And the current methods of getting nicotine is cigarette smoking, shisha, cigars, pipes, smokeless tobacco, electronic cigarettes, and heat, no-burn tobacco cigarettes. And I'll talk on each one one by one. So cigarettes, this is, although it looks very crude and very way burning, but this is the most effective way of delivering nicotine to the brain. It goes directly to the brain. And while shisha, it's burning the nicotine over time, whether it's filter, exposure, it is similar, so it's combustion. So there are two ways of delivering nicotine. You burn, get it through the lung directly to the brain, or you have the smokeless tobacco, sniffing, chewing, and the electronic cigarette, and we'll pay more attention or focus on this more. And the newer one, which is heat, no burn, which is the IQOS. Maybe some of you heard about it. The e-cigarettes have developed over a very short period of time as an alternative to cigarette smoking, and it's been claimed to be of having a less harmful effect on the human. So the first generation, which is called e-cigarettes, so it resembles the cigarette, okay? And then this is the second generation, and then third generation of the vapes. I think this is the most common one. And all of them, they have one simple technique, which is vaporize. It's not a vapor, it's making an aerosol. So they mix the oil with nicotine without burning, without combustion to the human body. And then there's the newer generation, which is the Juul, and this is the most, I think, dangerous one because it's smokeless, odorless, and it gets into the teenagers much faster, but it has the same concept of aerosolizing nicotine and getting it to the body.
The problem here, doctor, is that now it's attracting people who've never been smokers. They
Yes.
like the idea.
Yeah.
Having a USB in their mouth.
Yeah. So, as I said, nicotine is a psychoactive substance, and it's the least harmful substance in the cigarette. So it gives us an effect. It can cause, increase the viscosity of the blood, increase the risk of, having clots, coronary spasm, but it's the least harmful in the cigarette. So what's harmful in the cigarette, it's the carbon monoxide, the carcinogenic substances that occurs with burning the cigarette.
For the recent deaths in the US, is it linked to this type or another type?
So I'll talk about this. So having the e-cigarette, so they thought by avoiding the combustion, it will be safer. Okay. However, the deaths in this, so this was introduced, number one, as an alternative, a healthy alternative, or as a bridge to quit smoking, okay? And none of them has been shown as an effective because the cigarette, although it's crude and you burn it, the amount of delivered nicotine, surprisingly, is very stable, 1 to 2 milligrams of nicotine per cigarette. But in the electronic cigarettes, it's very variable. So sometimes it will deliver 1 milligram and sometimes can give you above 10 milligrams. Okay, so whoever thinks you can use it as a bridge to quit smoking, In fact, it will keep you up and down, and it may make you more addictive to nicotine. The recent deaths in the States, because we are seeing a new monster. You know, with cigarettes, we know what happens. We know what the natural history. You know, it causes lung cancer, and it occurs after time, heart diseases, heart attack. But what we are seeing now, it's like a burn injury in the lungs. And it's not time related, not like with smoking. The more you smoke, the more risk you get. But here, what we are seeing it's in teenagers. You know, they've been smoking the vapes or e-cigarettes for a few months or a year, and then they come with terminal illness. They die. And it's like, we call it chemical pneumonitis, which is burning as if you're putting, you know, something like a burning chemical on the lung, and then they die. They lose the function of the lungs. Now, the states, some of them, they argue it happens in people who have used the electronic cigarettes with THC. So it's like the cannabis. So, and some of them, they say, well, it's not the nicotine one, but it's the one they've been using cannabis electronic device. And some of them, they say it's because related to the vitamin E acetate, but no one knows. Okay, no one knows which one it is, but we know it's bad. And it's all money driven. So this Juul, this is, you know, it's a sub-company of Philip Morris. So it's the same giant that's been selling cigarettes.
And comparing the cigarettes with shisha, there are like rumors that it's like smoking 20 packs. So comparing both, which one has more harmless effects?
Okay, so as I said, nicotine is the least harmful substance. And I said it's the combustion, the burning. Anything burning is bad. A well-done steak is bad. A toasted bread is bad. Oxidants causes cancer. And this is what's killed you. So logically, if you shisha, which you know, a cigarette, it will take you a couple or 5 minutes at most to finish one cigarette. You know, shisha, you would stay smoking it for an hour or more. So it's more, I think, carcinogenic material there. And the latest kid in the block is the IQOS. Yes?
There are, I think, 70 chemicals or something in the cigarette and electronic cigarettes. There is less harmful. Is this true? Or?
So as I said, with, you know, more than 70 cigarettes, lots, okay? And some studies, they counted it in hundreds, some of them in thousands, but you are dealing with two different monsters. The electronic cigarettes, now, like if what we noticed, you can have a burning chemical reaction. And this could be fatal, which means if it occurs, boom. And this is what we see now, lots of deaths in the States now. Are they underreported here? Are they happening? Yes or no? Is it related to the process, to the glycerine or the glycol? Probably. Okay. So which one you want to bet, this or that? You have to pick.
Is there symptoms before you get like immediately death?
Yes. So what they have, he will have a cough, flu-like symptoms, and then goes to the hospital. He's having failing lungs. So our lungs extract the oxygen, so you'll have difficulty in breathing, and it's acute, usually acute, which means it happens very fast, rapid. And I think one of them, he was lucky to have a lung transplant, and most of them, they die. And the few who have survived, they ended up with, a very bad lung function. Then the, tobacco company, they didn't stop here. So they developed a new system. They said, okay, if the cigarettes are bad because of the combustion and burning, and if the e-cigarettes are bad because we don't know what we're going to deal with, they developed this IQOS. So IQOS, it's heat, no burn. So as if you're baking, so there are specially sold cigarettes that you put them in the device that heats it to below burning temperature to deliver the nicotine to the body. They claim it's less harmful, but again, when we say studies, I used to think all studies in medical profession are all pure, and they provide us the evidence, but most of those studies are funded by the industry, and they direct the study to go in one direction. And we don't know what's the long-term health effect on the human being. Benefit of smoking cessation. So as I said, I don't argue. I used to argue with my patients, and I used to get upset when they come with a heart attack, and I tell them, this is what's happening. You need to stop smoking. But then my goal ends by explaining to them the benefits of what's happening, because lots of our patients, especially local patients, they say, well, my neighbor is 90 years old, he smokes 2 packs a day. I said, well, he's lucky. There are some patients, even if you point a gun at him and you shoot him, he will not die. And another person, if you clap beside him, he will die. But if someone who already had an event, he already had a heart attack, he already had a heart damage, he cannot take any chances, and he has to stop. So the benefit of stopping smoking after a heart attack is unquestionable. And the maximum benefit, if you stop before the age of 40, but even if you stop after the age of 60, 70, the effects, is still there. This is a diagram of the heart. I describe the heart as a pump that circulate the blood around the body. But this is what we call it the coronary artery. So the heart supplies the blood to the body, but what supplies the blood to the heart itself is the coronary arteries, or sharayin tajiyya. This is what we speak about and what we refer to if someone have a heart attack or jalta. If one of those arteries get blocked, someone will have a heart attack. And I put the title here, Stents Are Not Miracle. Although this is my job, if someone comes with a heart attack, we see, this is if you take a cross-section of the artery, and you see the buildup inside here in yellow. So yellow means fat, and there are white dots, which is calcium, and it happens with to air and water, they will rust. So likewise in our coronary arteries, if you expose them to bad conditions, they will be blocked. And in my job, what I do here, we put a wire and then we open the blockage with a stent. But I always remind, and I show this picture to my patients, it's not a miracle. What we are doing, we are temporarily pushing this fat to the walls. So if you don't control the factors that cause this problem at the first place, this can reoccur again and will hit you back. This is a pathology specimen. So this is for patients, a patient who died. This is a patient, a cross-section here. Those dots are the stents, the metal ring. So here, it's a patent, it's open, nothing has happened to them. But smokers, what they develop, see the stent is open, but they build up a new build-up inside the stent, and then they will have a closure. I used to think that there is a sweet spot. Yes?
The build-up is made of what?
Yes, so this is all glycogen from smoking. So this is, we call it neoatherosclerosis. So it's the body reaction to the toxins that we get exposed to from cigarettes. And I used to think that there is a sweet spot in the cath lab. So when I do the operations, my patients are awake. We don't sedate them. So if someone have a heart attack, we take him to the cath lab, he's awake, we give him a mild sedative. And I used to think, you know what, if I talk to him now and I tell him it is the smoking, they will stop. But I get surprised, some of the people, your heart attack, I just found the problem, it's a blocked artery, I'm gonna start treating it now, and it is because of, your diabetes and smoking. قولي دكتور اسمح لي السيجارة. Okay, so, and I used to get upset, but as I started with the slide of psychoactive substances, we as a humans, I don't think we seek happiness, we seek peacefulness, and some patients, coming back to mental health, it's really coming back, maybe getting back to mental health and what to do, for our health. Okay, so here, this talk today is for a person who wants to smoke. If someone who doesn't believe or who doesn't want to smoke, who doesn't want to stop smoking, there is no point of arguing with that person. It's just time, remind him about the health effects of that. So the risk for smoking cessation is nicotine withdrawal. As I said, it's an addictive substance. If you stop it all at once, you will have withdrawal symptoms. You'll be irritable. You will be, your appetite will increase. You will have a weight gain. You may get a depressed mood. You may have an insomnia, difficulty of sleeping, irritable, frustration, anger, and anxiety, difficulty of concentration, and restless. That's why it's very important to counsel the person who wants to quit smoking before. And I am against a cold turkey cut. So someone said, well, I'm going to pick a date. I can do it. I want to stop. I'm against that approach. So the first steps of smoking cessation is willingness to quit. Okay? And there are 5 stages. We call it a pre-contemplation. So if someone doesn't want to smoke, or doesn't want to quit, he just want to continue, okay, fine. You just explain to him. That's it. So we call this stage pre-contemplation. And then contemplation is, well, you know what, I know it's bad, but now I'm young, I want to continue smoking, I just want to finish this project or this period until I get this promotion, and then I will think of quitting. The third stage is preparation. No, it's time. I want to stop, but I don't know how. And it's either he will ask his friends with Duaniya, or he goes to a clinic. And I have a friend who wanted to stop, and he went to one of the smoking cessation clinics, and he told them, I want to quit smoking. And unfortunately, that doctor, what he gave him like booklets and brochures about the health effects, the negative health effects of smoking, and الجنة والنار. يقول أنا بقطع, I want to stop. So why you're giving this? And then he got upset, and then he left without stop. So getting the right, and it's there are, I think, few dedicated places where they help people to quit smoking. And then, so preparation, and then you have the starting phase, and we'll talk about this, our emphasis, and then maintenance. With any addiction, there will be relapses. So whoever tried or want to quit smoking, he have to understand that it is, the success, depends on the willingness and the type of nicotine replacement and medication, but there will be a relapse. Okay, so first willingness, then calculating nicotine consumption. And I think this is the most important part. And I'm sure some smokers have experimented themselves with trying nicotine gums or nicotine patches, and I'm sure all of them, they don't know how to do it right. Because each cigarette has, as I said, 1 to 2 milligram delivery of nicotine. So in one pack, you have 20 milligrams of nicotine per day. So you have to replace it 1-to-1. And the patches, they come in different strengths. So they have 7 milligram, 40 milligram, and 21 milligram. So if you smoke 1 pack a day, which is 20 milligram, and you take a patch of 7 milligram, it will not do anything for you. Okay? So you have to calculate how much. So roughly, each cigarette is 1 milligram. So if you smoke 2 packs a day, that's a 40 milligram. And you have to replace it 1-to-1 with nicotine replacement therapy. And then, so calculate the nicotine consumption, and we'll do an exercise. And then setting a quit date. So you want to plan it. I'm going to quit on that day. And then replace the nicotine with or without medication.
If they want to quit, they go from like red to less, Marlboro red, and they go to white, and then
Nicotine is nicotine.
it's
Nicotine is nicotine. I think this is all, it's all a myth. And I think the difference between red, white, silver, they're all bad. I think it's a matter of how you cure the tobacco leaf. Cure is, when you get the tobacco leaf, it's green. You cannot smoke a green. And the more expensive, or cigars, they're more expensive because they are all leaves. And it depends, the leaves, they come in the way how the plant was, مثل النخل. And the way how they cure it, whether it's open to air, whether it's in smoked, whether it's in heat, etc. So I think smoking, the main problem is the burning, okay? And then coming from black, red, or changing brands, it's all a matter of flavor. So I don't think that's a good approach. Okay, so the good approach is, are you willing? How much nicotine you are getting? And then replace it. So we talked about the nicotine consumption, set a quit date, and then types of treatment. So behavioral therapy, I'm not an expert with that, so you will see some psychologists, they will talk to someone, whether it is, some people, they say, well, it's a habit. You know, I'm used to holding the cigarette with one hand, I cannot leave it. I'm not sure about that. You are addicted to the nicotine, and that's a fact, and you have to know that. It's as if someone, he said, well, you know, I like the sense of the cigarette in my hands. You know, money is money, whether it's a cash or a credit card. So if you're addicted to nicotine, I will give you that nicotine. So whoever smokes, who smokes here? Anyone? No one? No one? So, okay, so how many, do you mind? How many packs do you smoke a day?
I don't smoke, I smoke cigars.
Okay, how many packs a day?
Cigars is around 3 cigars a day.
So cigar. So interesting. So cigars, most of the absorption is from the mouth, okay? So they don't inhale it very much. So I'm not encouraging you, but the long-term health effect is maybe a bit less than the cigarettes, because cigarettes, you have to deep inhale it, so the absorption is from the lungs rather than from the buccal mucosa. But, huh? Maybe he can afford it.
I have things to say. I think why the people really continue smoking.
Yes.
I don't know what to say in English.
Yes, and that's what I said the first slide. It's the psychoactive substance, you know.
And they want to enjoy more and more.
Yes.
And who can really quit them?
And that's it, you know, because we want, as I said, human beings from the نشأة الخليقة, they want psychoactive substances. Some of them have, you know, a good effect, bonding. مثل now what's, you know, مثل ما تفضلت المتعة, maybe this is a personal enjoyment. So there are some habits, يعني مثل Native Americans, they smoke tobacco in groups together. And then they get high and then they enjoy it. Some tribes, they use the psychedelic mushrooms. So they hallucinate together and they feel the connection with their ancestors, etc., etc. But back to the topic here, so if you smoke 3 cigars a day, what I can tell you, can you smoke 10 cigars a day? In one day, you can't.
I don't enjoy it.
Yeah, you can't, because you will get nicotine overdose. So you will feel nausea, you will feel nauseous, you will feel lightheaded, and you may even start vomiting.
Yeah,
Okay? Because this is the nicotine overdose, okay? So behavioral therapy, so back to the type of treatment. Behavioral therapy, as I said, I think of it as an addiction. It's not to make it a stigma, but to be able to treat, we have to acknowledge the problem. So you enjoy the pleasure of getting the nicotine, not more of the cigar. The behavioral attachment, cutting the cigar, getting the proper one, the leaf, etc. It's part of the experience, but more it is the nicotine. So behavioral therapy, this is get from a psychotherapist. If you think, you know, it's more, there is a more of a habit thing. And then nicotine replacement, and we'll talk this in details now. And then there are centrally acting medications. So whoever want to quit, again to re-emphasize, he has to have the willingness. So if you are not willing to stop, no matter what I do for you, I will not be able to convince you, and there's no point of talking about this and wasting time. So here, this is a graph, so nicotine withdrawals, and that's the first side effect that happens after you stop quitting. So this is a smoker. So those are the spikes, are your desire to smoke, to give you the intended effect that you want from smoking. See, you have 3 spikes. Whenever you have a spike, you'll smoke, it will go down. But if you quit here, this is your quit date, and then you have red spikes, of nicotine withdrawal symptoms, whether it's anger, irritation, insomnia, depression. But with any addiction, you see the withdrawal symptoms, they peak, they get worse at the beginning, and then as time goes by, they become much less. And that's why I don't recommend cold turkey, which means I'm going to pick a date, I'm not going to replace anything method.
Yeah, doctor, why do people return?
Return?
After years sometimes. 1 year, 2 years.
Very simple. Because we as a human, we strive, no, not culture, we strive for peace of mind. This is our desire. So if I can tell you, they get back to it because they feel stressed, they feel uncomfortable. He wants something to make him calm, whether this is money, whether this is nicotine, or any other recreational substance. Yeah, but if I can tell you, you know, and this is, unfortunately, it's both applies for the poor and you know, wealthy people. They want the peaceful of mind. Okay, whether they're going to get it power or money, but this is a very easy way to do.
In the beginning, we spoke about that we need more keys for the
Receptors, yeah.
Yeah, receptors. After it quit, does these go down?
Yes, so they down, we call it down regulation. But imagine the door. Now that door in a normal person needs only one key to open that door to get the relaxation effect. But with smoking, you made that same exact door, you put 10 locks for that door to be opened. Okay, so with your normal substances, plus the nicotine you are getting to get that pleasure. So during the first phase, while the locks are still there, you cannot relax the first, you know, and typically it's 2 to 3 weeks. You'll feel very irritated, very nervous, and then the body will down-regulate and bring those receptors number down. And here, as I said, the most efficient way to get the nicotine to the brain is inhaling. Because once you inhale it, it goes to the lung, directly to the left side of the heart, boom, to the brain. But if you get the nicotine from other sources, like a patch or a gum, no, it has to go through the veins goes to the liver, and then some of it will be break down, and they will eventually go to the brain with a lesser amount of effect. This is how the concentration of nicotine goes up in the body. So chewing tobacco, you know, it used to be very popular in the past in America, or few parts of India, but now it's becoming again popular again in the States, sniffing and chewing tobacco again. So this is from time 0, and it goes quickly up and then stays. That's why they do it. But with the blue, which is the nicotine gum, it takes time until it builds up, and then it wears off quickly. So the goals of nicotine replacement, so let's say someone smokes 1 pack a day, so that's 20 milligram of nicotine. You want to replace it 1-to-1. So that's 20 milligram, I want to give it as a baseline. So the first thing you identify, so 20 milligrams, so you pick the right dosage of nicotine patch. And as I said, they come in different strengths, 7, 14, and 21. فما تروح والله الصيدلية والله okay عطني لزقة وعطني ميكا. No, you have to pick the right number. So you pick the 21 milligram and you educate your patient. This patch stays for 24 hours. You shave your arm. You don't put it on an area where there's lots of hair. And I usually tell the smokers to put it at night before they go to sleep. You have a shower, you put it. So the concentration will take time, it builds up. So when you wake up in the morning, you have some baseline of nicotine in your body. The problem with a patch, it gives you a steady state. So it replaces some or most of your nicotine requirement per day. But notice here, there are some urges. هذه سيجارة بعد الغداء. هذه أنا ما أقدر لازم. زين. So you need to top up those urges with short and fast acting nicotine replacement. So you wanna get that baseline, and then you wanna top up those things. So how you do it? You do it with some methods that we're gonna talk about, which are the nicotine gums or inhalers. And the goal, as you see here, the smoker, so for a period of time, a week or two, we tell him you need a nicotine patch of 20 milligram for a week or two with the gums, and then he comes for a follow-up, and then we decrease the nicotine patch from 21 down to 14. So there is a titration. مو والله حط لزقه وخلاص ولا ما نفعت معاه. No, it needs time and needs a calculation every time to make sure you are getting the correct dose. So we talked about the nicotine patch. It's applied once daily. That's one of the pros. And we give a steady baseline. It's less flexible. يقول واحد أنا أخذ شاور خاصة إحنا عندنا بالكويت يقول أخذ شاور مرتين باليوم. فوالله إذا خذيت شاور شلتها طاحت تحط واحدة ثانية. You have to rotate it. It may cause some skin irritation. And there is no limit. So if واحد يدخن 4 باكيتات في اليوم, you put 4 patches. Okay?
4 patches لازم كلهم.
Yes, but the correct dose.
Yeah, exactly.
Yeah, so it depends on how much you smoke. The mouth absorption, we have gums, lozenges. Lozenges are not available in Kuwait. مثل الحلاوة, مثل الستريبسلز. الgums. The problem with the gums, it's not a gum. بعض الناس حسبها العلشة قاعد تعلج فيه. No. And they think the absorption is from when they swallow it. So فأنا أقول لهم هذا مثل القات. زين؟ علشتين, 1 or 2 bites. Once you have a flavor, you keep it between your cheek, between the groove here. Because the absorption of the nicotine is from there, like the cigars. However, you should not be eating, if you're going to take it, you should not be eating or drinking for 50 minutes before that. Especially acidic stuff. Colas, coffee. Why? Because acid bound to nicotine and prevent absorption. فكأنك ما سويت شيء. Okay? And that's why Philip Morris succeeded in getting a big business. They were the one who found the first way how to cure tobacco and adding urea to make it more alkaline so the body will absorb it much faster. So the more alkaline the medium will enhance absorption, and more acidic, and unfortunately most of our food and drinks are acidic. Okay? فاللي بياخذ علش أقول له والله ربع ساعة قبل ربع ساعة ما تاكل ولا تشرب، وإذا تبي فرش أسنانك وتمضمض، خصوصا بعد عن avoid coffee, tea and colas, or all juices. And most importantly, if you have extra saliva, spit it out, don't swallow it. Because if you swallow it, أنت تعلت وبلعت السعابيل اللعاب, you will have relaxation of the gastroesophageal sphincter اللي هو راس المعدة. فراح يجي له حارج. They will suffer severe heartburn. دكتور أنا جربتها مت من الحارج. Because you're taking it the wrong way. So you chew it once, twice, you have a flavor, okay, and then you switch it to the other side. If you have extra saliva, you spit it out. They come in 2 different doses or strengths, 2 milligram and 4 milligrams. So if you take your first cigarette, 30 minutes or less after you wake up, it means you're more addictive. So you take the 4 milligram dose. If you take your first cigarettes after 38 minutes after you wake up, you take the 2 milligram dose. And there is no limit to the number of gums per day. Okay? Each gum equals 1 cigarette. Okay? So don't keep chewing on the gum for an hour or 2. Okay? And also, as I showed in the graph, it takes time until it builds up. You know yourself, immediately after lunch, I must have a cigarette or a cigar. Take the gum before your lunch. So build up your nicotine level before you get the urges. Okay? Last, there are medications. And this is the most common medication and effective medication. We call it Champix. It is safe medication. However, there are some people that we don't prescribe them, patients who have known psychiatric diseases, severe depression, suicidal ideation, we don't give them that. But the unique thing about this medication, it acts on the same receptor. So this medication goes to the nicotine receptors in the brain and bound to it. So it gives you a feeling of as if you smoked. And if you smoke, you'll get nauseous. Okay? It comes in 2 kits, a starter kit for the first 14 days. So they are numbered by days and doses, so it makes it easier. And then there is a maintenance kit. And usually the treatment has to be for 3 months. وايد ناس يقول والله جربت أسبوع أسبوعين شهر شهرين. No, you have to take it for 3 months. And I usually tell the patient, my patient, you can smoke. You know, if he's not willing, أقول له دخن. But take the medication. He will stop. One of the common side effects of it is you get vivid dreams. So I usually tell my patient, you know, this is what's going to happen. They're not nightmares, but vivid dreams. Full of details, colorful. يقول لكم تقعد أبطل بوكي وأعد الفلوس هالكثر. And that's, you know, if he's okay with that, he's okay with that. No, but sometimes they wake up exhausted. You go, اوف انا متهاوش مع فلان كذا وبطلت. But so by telling them, you're increasing the compliance and inhaled nicotines are not available in Kuwait, but the absorption is from the mouth, so they are like cigars. So you can have some discount. No, you know, you have to educate your patient how to use it. Okay, so unless someone want to start here, we can give an example. That's my talk, and I hope you learned anything. It is, you know, it is an addiction. It will have relapses, come back, but it all goes back to the, you know, the mental health. You know, it all goes back to that. All of us. If you ask someone, you want to be happy all the time, or you want to have peace of mind all the time? Most of the humans, they said, you know, I don't want to be happy all the time. I just want to be peaceful, relaxed. And that's what we strive for. That's why we have our first coffee in the day. I want my coffee to feel more energetic, more relaxed. And, you know, all of us in Ramadan, non-smokers, we suffer from the side effects of even caffeine withdrawals. And, you know, I think the worst addictive substance now, you know what? Sugar. We are all addicted to sugar now. Everything we add sugar, and, you know, if you stop eating, you know, sugar and this is all added to our food, you know, you feel crazy. Okay, thank you everyone. Yeah.
مشكور دكتور ما قصرت وذكرت يوم سبيكينج هذا. طبعا I'm non smoker وعايش في بيئة حتى باكيت سجاير ما عمري لمست بحياتي. أول مرة بحياتي ترى حضر محاضرة سموكي. I felt إن كذلك نحن علينا مسؤولية non smokers.
Yes.
يعني أنا whenever we have public campaigns about smoking, I feel I'm not part of this. إن أنا I don't care. أنا مو smoker. Why I care? أول مرة يعرض علينا التكنيكس هذا كنا نسمع chewing gum. يعني اللي بقوله our responsibility as non-smokers to understand the solutions and helping our colleagues and friends واللي بالديوانيات وغيرها to explain the techniques how to quit smoking. لأن المجتمع كذلك مو قاعد يساعد. حط لزقات شد لها تكنيك لها معادلة. فاللي بقوله كذلك يعني this is I'm very happy listening to this. At least I can help people to explain the concept. So really thank you for
So I had during my training in Canada, I went to Mayo Clinic and I had my certification in nicotine addiction there. So they have a ward for executives, so people who want to quit smoking. So they come in and they check in for 1 week. يدخلون 1 week to في ward بالhospital, a group of people, and then within 1 week they quit. They have part of the behavioral therapy, dealing with the nicotine addiction. طبعا ياخذون تليفوناتهم ماكو كذا. After the 1 week, it's done. معسكر. زين. I want to do that in Kuwait, inshallah. But you know, it's very difficult. You know, if you know, some people they use it. You know, the weakest point when لما يطيح الفاس في الراس. You know, I do treat patients with heart attacks. They are in their 20s. We think we are immune. We think we are immune, and we still think young. يعني, okay, we passed 40s, but now, you wake up, we started aging. And if someone want to reduce that risk, you can check. طبعا the other ways. طبعا احنا نتكلم على major population, major health benefits. But now what I do is risk screening. So someone comes to you, دكتور أنا عديت 40. I want to know what's my exact risk of having a heart disease. I don't want to die early. So there are things that we can do non-invasively, and without doing an angiogram, we do احنا نسميه cardiac CT angiography. So what we do بدون صبغة بدون شيء, CT scan, we see the amount of calcium on the coronary arteries. فلما أقعد مع هذا أقول له والله شوف فلان. Okay, although you look healthy, you play exercise every day, you eat organic, raw food, etc. But in you in particular, when we did the calcium score, the amount of calcium is way more than expected in you at your age, at your race. You have to now, even if he doesn't feel anything, we tell him now, you need to take aspirin. 2, despite your lipids that shows it's normal in your blood test, خلينا نقول LDL, which is the bad cholesterol, it's 1.5. لو بيشوفك طبيب المصاص يقول wow, amazing. But if we see the amount of calcium is high, you tell him no, that low amount is high for you, so you start treatment. And then you start convincing the person, you know what, maybe it's time now to stop smoking. It's not easy, and I think we lack, we see lots of campaigns, how to quit smoking, it's available, but there is no actual practical way, and it takes time and effort. So for me, as a busy intervention cardiologist, I do angiogram, this takes for me time. فهذا قاعد معي بالعيادة يمكن نص ساعة ساعة إلا ربع, where in this time I can see 3-4 patients, I do an operation that generate more money for me. So one other obstacle, it's not free. فتخيل الحين مثلا بالوزارة الصحة عندنا دعامات الوحدة $5,000 ستنت, وتبي gums وهذا الشغلات الأرخص, no, he have to go buy. الحين يقول بعد يعني هذا الشامب يكسر $20 والجمز ما جمزه 25, يقول لك الحين يعني you try to convince him وهو اصلا ما يبي يقطع, تقول تبي ادفع فلوس من جيبي عشان هذا. So I think those are the challenges here, and it goes back to what I first said, because it's not money generating, no one is interested in it. No one is interested in statistics. I don't think we have any good other than Kuwait Cancer Center. I don't think we have good research or statistics to show smoke. I'm not aware of them. I don't think we have a good research or statistics بالكويت يعني. We are not as good as you think.
Inshallah, by the end of this year, we'll bring you data about the percentage of the smokers within Equate. We are working on
طبعا the smoking, it's not only affects the person, there is the second-hand smoking, and then there is the third-hand smokers. So they did a study in Japan where they studied the housewives of a non-smoker worker who works with the smokers. And they found those house smokers, they are at a higher risk of getting lung cancer than the who are not exposed to tobacco.
Once I've read or heard somewhere that even the cars, the vehicles of the smokers, are not safe for his family, even if he's not smoking while they are there. Just being in the car, which is, because those chemicals are floating there. They, when you smoke, it floats and then gets on the chair. When you sit, they refloat again, and then they get, re-inhaled. And we see whenever you make a fire, you see your clothes get black and you get those residuals. But it is a problem. But I think to solve it, much attention should be put on mental health. I'm lucky I have a friend who's a psychiatrist in فضل مرات, زين. We don't have this mentality or culture. في مسلسل Billions. Anyone of you saw it? You see that they have a psychotherapist and a psychiatrist in the company. It's amazing, and we should think about that.
Seriously, if you want to invest in one thing as a company who has money and have a therapist here. Have a therapist, because it all goes back. I want to be peaceful. I want to be ما عندي مشاكل. أبي أرتاح. And you can get it by either way, not necessarily with medication. Because our culture هنا تروح دوانية تروح مكان بتفضفض يكبسك يعني عرفت شلون يا معود احمد ربك انت احسن من غيرك وكذا وكذي.
I support them.
Okay. Thank you, everyone. Thank you.
Thank you, Dr. Zarar, for this interesting presentation, and also thank you for our audience for sharing your expertise and asking those questions. So we'll be wrapping our event today by giving just a small token of appreciation to our lecturers. دكتور أحمد العنسي. تعال حياك هيك. ما قصرت. دكتور ضرار الخوير. Thank you once more, and inshallah we'll be seeing you in more activities, inshallah. Thanks a lot.